Okay. Good morning, everyone. My name is Hirmand. I'm one of the PGY6 cardiology residents. I'll be presenting on the assessment of the right ventricle today. We'll go over a little bit of the basics of the RV anatomy. We'll see some of the approaches to assessment of the RV size and function, and then we'll discuss some cases that involve right ventricular pathology. Okay. So the right ventricle has a thin free wall. It's crescentic shaped. The geometry is somewhat complex because it wraps around the left ventricle and it's asymmetric. It is normally a high compliance chamber to accommodate large volumes, and again, normally it ejects against low resistance of the pulmonary circuit. The RV anatomy can be divided into three main components: the inlet, trabeculated apex, and the infundibulum or the outlet. As you can see, the typical ways we differentiate RV from LV, other than looking for a typical location and the kind of the triangular shaped, is presence of a moderator band. Trabeculations at the apex, more apical attachment of the septal leaflet of the tricuspid valve, and septal papillary muscle, for example. The way the RV contracts also has multiple different components. It can contract along the long axis towards the apex, as kind of these two arrows here. It can also have an inward movement of the RV3 wall. The circumferential contraction of the RV outflow tract is the third component, and then the last one is the bulging of the septum. So the geometry and the way the fibers are organized with the various ways that it contracts all add to the challenges in terms of assessing RV size and function. So in terms of, this is just a very broad overview of the various different pathologies that can affect the right ventricle, with the end results of right ventricular dilation, thickened ventricular wall, RV hypertrophy, and ventricular interdependence with the leftward septal shift. Breaking it down, there's things that affect the RV preload, valvular regurgitations, left-sided heart failure, significant left-right shunts, RV afterload with mechanical obstruction with pulmonary embolism, pulmonary hypertension, that's precapillary like PAH, and then various primary lung diseases can affect the afterload. Reduced inotropy can happen in cases of post-surgery, post-LVAD, myocarditis, and RVMI. And then the last one, not to forget, is reduced lusitropy or a decreased relaxation of the RV that can occur in case of myocardial fibrosis, constrictive pericarditis, for example. So just with that basic understanding of the anatomy, we'll get into the different ways of assessing the RV size. Most of the slides here and the references come from the most recent AAC guidelines in 2015 for quantification of the recommendations on cardiac chamber quantification. Because of the RV complex geometry, it's not enough to look at it in one projection, and we have to look at different components of the right ventricle in different views. As we all do with the personal long axis, we do a general screening of the right ventricle. You can have a look at the anterior wall there. With the short axis, we look at any degree of septal flattening, tricuspid regurgitation. We can look at the RV outflow tract and any pulmonary regurgitation. In the apical four-chamber, we can look at the lateral wall, our right ventricle and right atrial size, as well as, again, the tricuspid valve. And then subcostal view, we can look at the degree of RVH and the IVC. So I think it's important just to spend a little bit of time on the RV focus view, as this will come up again and again in terms of some of the measurements. As you can imagine, kind of looking at the right ventricle short axis, there's different ways that we can cut through the right ventricle. Each of these lines here are numbered and correspond to each of these schematics down here. And ideally, we want the RV focus view where you can see the anterior and septal leaflets of the tricuspid valve, and it just allows for looking at the sizes in the way that they're standardized. And you want to make the RV look at its biggest, if we want to put it simply, when we're looking at these size assessments. So we'll start with the first one, that's wall thickness. Now, this is the one caveat. So this is looking at an RV modified view. So it's looking different from the view that I showed above. It's a very simple measurement to do. The normal, considering the mean and the standard deviation, is between 1 to 5 millimeters. You should exclude trabeculae and papillary muscles. You can see where the RV wall is shown here between the two arrows on the M mode. And also here, it can be difficult to measure if there is thickened visceral pericardium. And one of the issues with this measurement, although it's simple to do, you're only looking at the RV wall in one point. But the guidelines do suggest that it be measured in patients that were looking at RV assessments. The next one is RV linear dimensions. So this is where that RV focus view becomes important. The first one, RV1, is the inflow measurement. It is in the 1/3 of the basal RV with measurements over 41 millimeter considered abnormal. We're supposed to measure inner edge to inner edge at end diastole, and one of the downfalls of this method is, as I showed before, it's dependent on the probe rotation. This is the most common measurement that I think I've seen is done, but there are other measurements. The next one is the middle third of the RV, or you can say at the level of the papillary muscles, and the cutoff for that is 35 millimeters. And then lastly, RV longitudinal measurement, RV3, which is from the middle of the tricuspid valve to the apex of the RV. So I will show a table in the guidelines that shows the ranges for these measurements, and also the ways that they can be differentiated a little bit further based on body surface area. For another sort of RV linear dimension is the RVOT, RV outflow tract, that can be measured proximally, either in the personal long axis or in the personal short axis. It's from the anterior wall of the RV to the interventricular septal aortic junction. It is a little bit less reproducible in the personal long. In the personal short, you just measure it to the aortic valve. And the cutoffs, as you can see, are different, less than 30 millimeters and less than 35 for normal. Again, this is supposed to be at end diastole and inner edge to inner edge. And in the RV outflow tract, distal measurement is in the personal short axis, and it's measured just proximal to the pulmonary valve. So it is somewhat dependent on seeing where the pulmonary valve is to be able to find that landmark. Moving on from the linear measurements, we can look at RV area. It is essentially a manual tracing from the lateral annulus of the tricuspid valve going across the RV3 wall to the apex up the septum and then to the medial aspects. It is dependent on finding or having good quality images to look at endocardial border definition. Trabeculations and papillary muscles should be included inside that measurement, and it can be affected by foreshortening. It is the end diastolic area, as you can see, and it is not a true representative of the global size all the time, but it's another way of assessing RV size. So this is that table that I was mentioning earlier. As you can see, RV basal diameter, mean and standard deviation, and normal range is provided here, as well as the mid-diameter, longitudinal diameter, and the outflow tract measurements. Something that I learned as I was looking at these guidelines is that the outflow tract end diastolic area, for example, in men and women, is provided, but then they also provide normalized based on the body surface area. As I was reading the finer points in the guidelines, it looks like that the studies that looked at these normalized numbers based on the body surface area did not uniformly use the reference points for the RV focused view. So there is some limitation, but if it is a patient that that is somewhat outside of the norms of the body surface area, you can use this to try to get you a more normalized number, and hopefully that will be more representative of their true RV size. So moving from there, there is again various ways that the guidelines suggest for assessment of the RV function. I just want to raise a point here that was interesting to me as I was preparing this talk. There have been some studies looking at visual assessment of the right ventricle, which again is something that we commonly do. And in this particular one, they looked at RV size and systolic function, various quantification methods from echocardiography, and they also looked at cardiac MRI as kind of a gold standard. And they did find quite a bit of inter-observer variability, as you can imagine, with just visual assessments. And their conclusion was that using some quantification method of RV function helps provide more accurate and reliable diagnosis, and we should try to steer away from purely visual assessment of the right ventricle. So having said that, there's various ways for assessing RV function. The two most common ones that we see are the regional and longitudinal methods that I'll go over. There are some methods that are supposed to provide more of a global assessment of the RV function. I won't spend too much time on the strain and 3D RVEF, but I'll just mention them briefly. So starting with the TAPE-C, or the tricuspid annular plane systolic excursion, I think we have seen this very commonly. It is a longitudinal RV shortening. Like it represents the longitudinal right ventricular shortening. The abnormal cutoff in the guidelines is less than 17 millimeters, and we commonly use M modes to make this measurement. As I was mentioning before about the contraction of the right ventricle, it basically represents one of the an assessment of one of the four ways that the RV contracts, and it's the longitudinal muscle contraction. It is a simple measurement to perform. It is reproducible, and it's because of the location that we try to look at, it is not affected by trabeculations. It is somewhat angle dependent, and things such as, for example, atrial fibrillation can affect the TAPE-C, and it can cause a drop in it. The prognostic factor associated with this, one of the studies I looked at, which is a small one with 140 patients, and as you can see, their cutoff for the TAPE-C was 14 instead of 17, but they did show that there was a large difference in event-free survival with higher TAPE-C and essentially better RV function. Another study that looked at the correlation between right ventricular functional area change and the TAPE-C basically showed that there was a correlation. There's a lot of data points in here, but I think if you can imagine tape C of 17 being right about here and draw a horizontal line across, you can see that most of the subjects with higher fractional area change also had a higher tape C, and most of them with lower tape C also had a lower fractional area change, kind of dividing this curve into 4 quadrants. And there was fewer patients with discordance between the two measurements with a higher fractional area change but lower tape C, or the other way around with a higher tape C and lower fractional area change. Similarly, so the next one that assesses again the longitudinal myocardial fibers is the S prime tissue Doppler. This measurement is with the marker again over that lateral annulus, and it looks at the velocity less than 9.5 centimeter per second is the abnormal threshold. It is again a simple measurement to do, similar to tape C. It is angle dependent, and it is also again prognostic, with in this study by Damey showing that cutoffs over 9.5 centimeter per second had higher event-free survival. So moving away from those two measurements of DRV function that are more longitudinal or more regional, there is right ventricular fractional area change. This looks at the change between right ventricular end systolic area and end diastolic area, with a cutoff of less than 35 that is abnormal. And again, it is the tracing of the inside of the right ventricle that requires a good quality image to be able to see the endocardial definition. And here are examples of 60% change, 40%, and 20% with DRV being very dilated here. It is a reproducible measure, and it can be again affected by the angulation if we don't have that RV focus view. The RV fractional area change in a study that looked at correlating this with RV ejection fraction from MRI did show again significant correlation. Although the study only had 220 patients, and again seems to be quite a bit of scatter, but you can see that kind of imagining the RV fractional area change on this axis here with a cutoff of around 45 was normal, would correspond to most of these patients here with higher RV ejection fraction from MRI, and vice versa in this other quadrant with both values being lower. One way that we can assess the RV function that we don't use as much, and it can have some representation of global RV function, is the right ventricular myocardial performance index. So as you can imagine, if the right ventricle has higher loading conditions, or it's contracting against higher afterloads, for example, in case of pulmonary hypertension, the ejection time might be longer. And essentially this index looks at tricuspid valve closure and opening time, and then the pulmonary valve ejection time. And it's basically looking at the difference between those two values divided by the pulmonary valve ejection time. With there are two different ways of looking at this, either with the PW Doppler that with a cutoff of 4.43, and the higher this right ventricular myocardial performance index, the worse or the more abnormal the right ventricular function is. I think I have a better picture on the next slide. With the tissue Doppler, the cutoff is less than 0.54, and this is essentially where the if you can see the tracing at the bottom with the QRS complex and the isovolumetric contraction happening here with the tricuspid valve closure opening time throughout this. Sorry, the lines aren't showing up as well. From this dotted line all the way to here, and the isovolumetric relaxation time here, and the pulmonary valve ejection time down here. So it is essentially with this measurement, if you have a single beat, you can calculate the index, and it is helpful in cases where the patient is in atrial fibrillation. I think one of the caveats that I was reading about is it may not again represent the global right ventricular function. So moving on from there, I'll just mention the next two slides. So right ventricular strain is another method of assessing RV function. There is a degree of variability between vendors and between different device manufacturers, and I think in the 2015 guidelines, it's not actually kind of formally recommended as a way of assessing the RV function. But you can look at the degree of myocardial deformation compared with the original length, and again, it is dependent on the angle of the probe, and it is dependent on seeing a good sort of outline of the myocardium for the software to be able to track it. There is an abnormal threshold of less than 20% mentioned. And I think it is one of those areas in echo that is still up and coming in terms of, for example, cases in cardio-oncology that's more relevant to the left ventricle. But it is worth knowing about this assessment method, and we'll see if there is more data coming out in terms of right ventricular assessment with a strain in the future. And then the last one is the 3D RV ejection fraction. It correlates with RV ejection fraction from cardiac MRI in the normal over 45%. It is again. I think one of those methods that the data and the numbers in terms of pathological cases has not been well established, and it is a time-consuming way of assessing right ventricular function. It does require some training to work with the software and for the sonographers to be able to do this. The myocardial trabeculations and moderate band should be included in the right ventricular cavity in this case. I think one of the powerful methods or powerful points with this is that it does not have any geometrical assumptions when it's looking at the right ventricle, because it is ideally truly looking at the global right ventricular function in this case. So I think that's all I have for the right ventricular size and function assessments. This is table number 10 from the 2015 guidelines that provides a summary of the methods that I talked about with, again, mean and standard deviation. We usually, and then the abnormal thresholds that I mentioned for tape, CN pulse, Doppler, S-wave, as well as the fractional area change. So, next, I thought I would highlight some cases from St. Michael's Hospital that involve right ventricular pathology, just to make this a little bit more interesting. I have 4 cases. I will go through them one by one. I'm not sure if anyone is interested in making comments or trying to. They're simple cases. I don't know if the residents like to participate. If not, it's okay. No pressure. Hi. Yes.
Before we start the cases, I just I know RV is like one area that we don't really optimize. That's to say, yeah. So we usually assess the RV just based on the top C or the S prime, right? And so my question is, how do we optimize the RV? When you say focus view, what does it mean? For us, focus view could be like you zoom on it, right?
Mm-hmm.
How do we do the focus view?
That's a good question.
To assess the true size.
Yeah.
And then the function of the RV.
Let me go back. Hopefully, I won't lose that. So the guidelines have a couple of nice figures on this. I only included one of them. So I think essentially what you want to avoid is and to your point, a lot of it is very visual and very much depend on the patient. But I think when you're doing the RV focus view, these two are basically what you want to avoid. So if you're cutting through kind of closer to the mid RV or to the RV apex, you can make the RV inflow look smaller than it is. And again, you can make the longitudinal RV measurement smaller than it actually is. So it's not just zooming on the right ventricle, but it's angulating in a way that you can see the lateral wall of the RV, and essentially the RV apex is kind of pointing more laterally in a way, if for lack of a better word, for explaining it.
Sure. There is like
Sorry, go ahead.
There is a definition like it's just try to keep the apex in the image, however, try to show the maximum of the RV. So just like do not lose the LV, so find the apex and show us the maximum diameter of the.
Actually, Nouraei talks about this all the time. He was the chair for the RV guidelines. I think they're actually in the process of updating the RV guidelines, so probably in the next year or so. And actually, there's a nice description about how to do it. Having said that, it's hands-on practice. So, as you mentioned, I think one of the things to remember is that you want to make sure that you keep the LV apex at the top of the triangle. And then you tilt it so that you focus more on the RV, which is why it's the RV focus view. And you can try and rotate the portfolio and try and maximize the size of the RV while keeping the LV impact. And one of the things, at least the benefit of TAPS in RVS prime, is to try and be parallel to that focus angle so that you don't underestimate the RVS prime and the TAPS. And you can play with a little bit of rotate to try and get the largest RV or as large RV impacts, large RV diameter, while keeping the LV impact.
There is I have a comment just regarding the measurement of the basal RV diameter. Sometimes, even in the images just now, some will measure this area exactly at the roll, and we'll go a bit.
The key is don't measure the tricuspid angles. That's a good one.
Yeah.
So you measure myocardium to myocardium, and ideally, probably tips of the tricuspid inputs are probably the best, at least as a landmark. Just be aware of trabeculations on the RV lateral wall and ports.
So what happens when the basal RV is dilated, but by visual the actual RV doesn't look dilated?
Yeah, so the RV basal diameter is one parameter used to assess RV dilation, but you have 6 or 7 other views to see the RV. All the times will use it. So I think the interpreter has to, you don't have to stick mainly to the basal diameter. You just have to recognize that if you're gonna call it differently than the measurement, either the measurement's off, in which case you might want to decide not to use the measurement, or if there's other factors why you think that it doesn't match the RV basal diameter, which you have to include in your interpretation. So you know that because it's just one, you might have a normal RV basal diameter, but it's dilated at the way up just because of remodeling, for example.
Great.
Whatever you said is right.
Have you ever reported a finding
RV. Yeah, you can. Some of the other ancillary measurements that Hirmand showed some of the other measurements that you could use. So.
Okay. Okay, so okay. Just give it a second. I'll give a little bit of a preamble. I guess it's this was a 60-year-old patient with history of CAD, and I don't want to give it away. Nobody wants to make a comment? I'm making eye contact with you. Sorry.
Your ears dilated,
Okay,
apex is akinetic. The rest of the segments are not contracting well either.
Yeah. Any thoughts about what might be going on just based on this one?
Like RV or
Yeah. That was the ECG. So they presented with inferior STEMI, complete heart block, or infarcts. Yeah, and I think, like I said, it's so the one thing I wanted to mention, the right ventricle is generally has a smaller mass. It does perfuse in systole and diastole, and it's generally thought to be more resistant to myocardial infarction, and even in the cases of RVMI, persistent RV dysfunction is actually quite rare, and it does tend to recover, but especially with cases of inferior STEMI, we do see, can see extension to the RV and RVMI. Okay, so that was.
So, one of the clues for RV infarction obviously is you want to see that because it usually goes in conjunction with an inferior infarct. So, one of the classic views is the parasternal short axis. And so the wall motion is in the form of an upside down T. It's the inferior septum, inferior wall of the LV, and then the inferior aspect of the RV extending. And usually the anterior aspect of the RV is relatively preserved. That's usually fed by branches of the LAV. So the RVOT usually is fairly well preserved in the midst of an RV infarct. So I remember this mentor of mine calling it a T sign where that's where the wall motion on the parasternal short axis.
Yeah, I tried to get the best views that they had for the case, but really this was one of the more clear ones. Yes.
Oh, you're not
In addition to the have this concern about focusing, optimizing the RV. So in personnel short axis, we sometimes just zoom in the LV for the RV. So I guess in the first path, you have a dilated RV or abnormal RV function. Always including the short axis as you sweep, as you take the LV from
Good point. Okay. So the second case.
Very dilated RV, there's a flattened septum.
It's almost like D-shaped. Good.
Sure.
I think I have two. Yeah, I have a second.
still going to be pushed away.
Yeah.
What do you think about this one? Same case, same patient.
Yeah.
So it was a man who had a motor vehicle accident, who was getting, who had multiple fractures, and had an echo as part of the workup. Anything on here that catches your eye?
Is a mono sign, like the apex is
What's the mono sign?
It's not.
So like it's severe hyperkinesis of the lateral wall in the L4 and with sparing at the apex. So This was interesting because, and then the echo report says for clinical correlation, as this could be suggestive of pulmonary embolism. This case, I thought I mentioned it because it's the patient did not actually have a PE in this case, and I believe they had like pre-existing pulmonary hypertension. Sorry, I'm having trouble moving on to the next slide. And so I just wanted to mention that about 30 to 40% of patients with confirmed PE can have findings in the echocardiogram. The findings can be anywhere from RV enlargement, decline in systolic function, tricuspid regurgitation that could be new or worsening compared to their baseline. In some cases, you can even see thrombus in the right ventricle or PE in transit that could be an indication for surgery in these patients. Or you can have increased pulmonary artery pressure. The McConnell sign, as we talked about, that lateral wall motion abnormality or severe hyperkinesis with sparing of the apex, is thought to be specific to RV, but it can also be seen in a lot of other pathologies and in our myocardial infarction as well. So there's a different sign. Sorry, it's overlapping with the text. The 60-60 sign is thought to be a bit more specific for right ventricle. I think one study commented on a specificity of about 93% with sensitivities, I think, in the 80s. But the thought behind it is that if there is sudden obstruction or increase in RV afterload, the right ventricle is not geared to produce high pressures acutely. So you generally don't see an RV pressure, systolic pressure of over 60. But the second component of it is that it's basically the change of pressure over change of time, or the dP/dt component of it. It generally drops below 60. So it is more specific in cases of acute pulmonary embolism. Sure. Sorry. There we go. You want the second one?
So why it's sparing diabetes? I don't know that.
So, but this patient said they have MI, right?
No, this is a different case. Yeah.
For example, this is a B. Why it's sparing diabetes? Why the diabetes is still in that? So they said that some of the theories that the apex is still supported by the muscular part of the LV. Okay, so the free wall is like thin and cannot make the resistance in front of it, but the apex is still, there is some power from that LV.
That's the theory behind why it's here. Pulmonary embolism. But why is this still spared in the setting of somebody with pulmonary arterial hypertension? Like in this case, that but I guess the other thing is to remember is that it's not 100% sensitive specific. Right? So there are going to be cases where you're going to see this pattern, and it's not. It's just the way it is.
That also affects the side of the artery, because we have three parts of the artery.
Yeah.
That's actually a curious one.
Yeah, I don't know why. I don't know if there's any data on for RBT embolism versus the initial study by McConnell actually only had patients with pulmonary arterial hypertension versus pulmonary embolism. So then we examined other causes of RV dilatation or exposure like RV infarct or
Thank you. I think we have a little bit more time. I'll just show the third case. This was kind of that initial screening in the personal long axis essentially. Any thoughts? It's not a trick.
Yeah, hypertrophy looks like there's something in the RV. Maybe.
I'll show you a different view.
Okay. Oh, okay. So a mass in the RV.
Yeah. So
versus tumor.
yeah, this was a lady with known history of osteosarcoma, had a previous below-knee amputation, presented with this mass in the right ventricle in the context of recurrence. And there were other views. Unfortunately, the quality wasn't that good, but it shows that there wasn't really any flow acceleration across the RVOT, so it was completely obstructing the right ventricle. And then there was one with contrast that essentially wasn't the best, but it shows there is partial kind of vascularization of the mass when contrast was used. So it is, again, one of those cases where contrast can help with the differentiation, but she had a previous kind of known history of osteosarcoma, so I thought it was just an interesting one to show. And then last one. Sorry? Yeah, so this is a patient with end-stage renal disease, uremic cardiomyopathy, had a secondary prevention ICD. And this is the, you can see part of the ICD leads, but is there anything else that catches your attention?
RV function.
Sure, I'll show you another view. So yeah, there's a mass. It would turn out to be a thrombus that's attached to the ICD lead that resolves after anticoagulation in this patient. Less so in terms of RV pathology, but things that you can see in the right ventricle, especially in the context of the ICD. Okay, I think that's all I have for the cases. So I think in conclusion, as you guys have mentioned, it is difficult to assess the right ventricle because of its asymmetrical shape, because the physiology, especially the way it contracts, is quite complex. There is limited data available on normal dimensions of the RV. And I think it's been established that visual assessment by itself is not adequate, and some way of assessing RV function in a quantitative manner is recommended. Although that the different methods have their own limitations, and there has been quite a bit of data that the RV function is associated with clinical outcomes and survival. So we'll see if the new guidelines come in the next year or two, and if that changes things clinically. Thank you very much.